Dr. Kamau is going to take us through aging in HIV. And just a snapshot, in KNH, within the CCC, we have our geriatric clinic, where we see around 3,200 patients. And the majority of our patients, 55% of these patients are female. And within the geriatric clinic, we look at different aspects of our patient. Here we look at the psychological state, screening for depression. We look at the frailty of our patients, the comorbidities that they have with the NCDs. We also look at a key component that is the same with the other patients, which is viremia, the viral load state, because this is something that is a problem within the geriatric population. So Dr. Kamau is going to take us through in detail what the aging process is with the influence of HIV and what we do within our facility. So I think Dr. Kamau can begin her presentation.
Thank you so much, Dr. Okatch. Thank you so much, Dr. Okatch, for the introduction. So today we're going to focus on the effects of HIV on aging. Give me 2 minutes for me to load my presentation.
Sorry, Doctor, it's not yet visible. Not yet.
For the technical hitch, I had to switch to bundles. Okay, so even as I continue, this was taken from our last year's World AIDS Day theme. It was on equalization. So how can we equalize for people who are living with HIV? And the goal is that by 2030, we should finish, the finish line is to get to the end of the AIDS pandemic by 2030. And for us to do that, we need to meet 3 targets three 95 targets. That means you get 95% of people living with HIV knowing their HIV status, 95% of people living with HIV on ART, and 95% of these people virally suppressed. And what this means is that there will be 0 new HIV infections, 0 HIV-related deaths, and 0 HIV discrimination. And as you look at the status as of 2022, in 2021, there were 1.5 million new HIV infections. And when you look at it in 1996, it was about 3.2 million. So things are getting better. We are not yet there. In 2021, 650,000 people died from HIV-related causes. In 2004, we're talking about millions. And this is actually from the whole world. And when you think about stigma, over a third of patients experienced HIV-related stigma, and there is more stigma for the key populations, and this hinders their access to services. But now begs the question, what about the quality of life? As much as we have such great plans for having 0 new HIV infections, 0 HIV-related deaths, and 0 HIV/AIDS discrimination, which will actually impact on the quality of life, what does that mean for quality of life? So while ART has successfully prolonged life for people living with HIV, HIV shortens their lifespan by 10 years, and we'll see why in the next slides. So basically what we are saying is that ART has prolonged life for people living with HIV, but HIV has shortened it. And when we think about the quality of life, we need to ask ourselves, what is this fourth 90 or fourth 95% that we should be thinking about? That 95% of the people living with HIV will have self-reported quality of life that is good. And this ensures that people living with HIV experience healthy aging. And it also means that we need to improve the quality of life for people living with HIV. So when we think about this, we think about healthy aging. So older populations have not been prioritized in HIV prevention and treatment programs. And people living with HIV are living longer because of universal ART. But what we've noted is that the access to ART is disproportionate among populations. And when you think about HIV programming, there's really nothing for the senior citizens. So if you say that, and there's nothing that is geared towards, prolonging life expectancy for people who are living with HIV, and there's really nothing that is prolonged around, there's no programming around, senior citizens, people who are probably above 60, people who are above 50, they've retired from work, and there's nothing targeting, HIV prevention, HIV transmission among senior citizens. And this is probably because of our understanding, and our focus has been in so much getting people to survive, getting people to live longer, getting people to be on ART, but there's not much about, understanding what the effect of aging is on HIV, and also the effect of HIV on aging. And then really think about where our population is and where our cohort is. In Kenyatta, we have close to 10,000 people who are living with HIV. And having been working in this HIV clinic, what I've realized is that people are living longer. So as a pediatrician, the children that I used to see, the population of children at a certain age is not the same, because children have grown older, they have aged out. And so the people who started ART 20 years ago when they were 30 are now 50, or when they are 40 are now 60. So what has been the effect of aging on HIV, and what has the effect of HIV been on aging? And with that understanding, we can actually improve the quality of life for people who are living with HIV. And we think about aging, really what is aging? Aging is the gradual loss of physiological integrity, leading to heterogeneous decline in organ function. And this is a process that is eventually stopped by death. And it's characterized by the body's reduced ability to combat stress, increased frailty, and increased rate of development of age-related diseases. And around HIV, there's a thought that HIV itself accelerates aging. it either accelerates aging or accentuates aging. And it's not really clear whether it accelerates aging or it accentuates aging. So when you say accelerating aging, what it means is that you get the same age-related diseases in people who are living with HIV at an earlier age. And when you say it accentuates aging, what you mean is that HIV itself is a risk factor for the development of comorbidities, and these are the age-related disorders. And when you're talking about the age-related disorders, you're talking about NCDs such as cancer, you're talking about frailty, you're talking about metabolic, bone, and neurodegenerative disorders. You're also talking about cardiovascular disorders. So it's not really clear whether it's accentuating or accelerating aging. So it means that we really need to understand it better. But studies point out more towards accelerating aging. And we'll see why. So premature aging in HIV is the result of an interplay of many factors. It could be because of HIV infection itself. It could be because of the chronic immune activation it causes, the chronic inflammatory state caused by HIV, the effects of ART and other viral co-infections such as CMV and hepatitis B. And when you look at this diagram, it sort of like explains the NCDs, OIs in HIV and really what aging is all about. So there's HIV production and replication, and there's loss of regulatory cells. And there's also the leaky gut, which causes translocation of organisms within the gut. So what that does is it actually causes inflammation, and HIV itself actually stimulates inflammation. So as a result, you get increased monocyte activation, increased T cell activation, endothelium adhesion, dyslipidemia, and hypercoagulation. And remember that ART itself has toxicity. You can get dyslipidemias because of your protease inhibitors. Things like abacavir will increase your cardiovascular risk. AZT and the likes cause lipodystrophy. So all those factors are playing around and actually accelerating aging. So, as a result of all these factors, there is an imbalance between homeostatic and repair mechanisms, both at the molecular and cellular level, leading to disruption in function of different physiological systems, which includes the immune system. So the disruption in the adaptive and innate immune responses leads to a phenomenon known as immunosenescence, and accumulation of senescent cells in various organs and tissues in the body will lead to the metabolic failures that ultimately facilitate or accelerate aging. So really, this is what goes on to actually accelerate aging. So we've talked about your ART, NNRTIs, and NRTIs, PIs, integrase inhibitors, HIV reservoirs, things like CMV and the increased gut permeability. And let's not forget the lifestyle factors, because people living with HIV will also take alcohol. People living with HIV, and especially because of instincts, will be obese. And all these things are environmental factors, poverty and social isolation that comes from HIV. And this results in the aging mechanisms, which are enhanced in HIV infection, things like inflammation and the cellular senescence that I talked about, telomere attrition, epigenetic alterations, and mitochondrial dysfunction. And as a result of all these things, you see cardiovascular diseases, chronic diseases, malignancies. These are the non-AIDS associated malignancies, osteoporosis, neurocognitive decline, and frailty. And the levels of inflammatory cytokines that are seen in people living with HIV are similar to those in healthy controls 4 to 12 years older than them. And it's as a result of this chronic immune inflammation due to the chronic immune activation that that is seen in HIV that is associated with the development of all these comorbidities. And we've also talked about the direct effects that HIV has on other mechanisms of aging, like proteostasis, mitochondrial dysfunction, and stem cell exhaustion, and this epigenetic alteration. So ultimately what will happen, along with all these lifestyle factors, is that you will accelerate aging. So as a result of aging, there will be development of other non-AIDS associated conditions at a higher rate and earlier than in the general population. So this has been well described in people living with HIV, in mainly adults. And these conditions that we already talked about are the ones that will be seen much earlier. So I think I want to throw a spanner in the works and ask people whether we think that children will age also. And the reason for that question, much as I've not put it in the presentation, I just wanted us to think about what does this mean for children who are exposed to the virus in utero and even and in utero, and also they have a longer exposure to the virus, and also for children who are also exposed longer to ART and will be on it for lifelong, for the whole of their lives. So there's limited data on, the clinical manifestations in various organs. So there are studies that have talked about probably one organ system, and really what has been done a lot is, the effects of HIV on neurodevelopment in children. But really thinking about all this being related to aging has not been well studied. And I think that's one thing for people who are in the room to think about. So I think we just wanted to make this small call for us to understand. We've really been thinking, as a result of the effects of aging and what has been described in the literature, we've really been thinking about how to integrate NCD screening within our CCC, and also to see whether we actually have a lot of these non-AIDS associated chronic conditions within our population of people who are living with HIV. So what we decided to do was just call the people within the clinic, and really this was a non-clinical, screen. So what we did is we had some peer counselors who also people living with HIV, just to call people and ask them, do you have any other chronic condition apart from HIV that you're taking medication for? And this is supposed to help us pilot our integration and find out whether people do we have NCDs? What are the NCDs? We expect that 30% of the people living with HIV within our population have NCDs. So from this pilot, we managed to screen 4,585, and this is slightly less than half of the people who are living with HIV in the clinic. And we recorded 1,001 people living with HIV with NCDs, and this translates to like a prevalence of 22% on half of our population. And because our clinic is mostly female, we found that there are more of the NCDs among the female than the males. And this is one thing that I just want to show proves that, we are actually having accelerated aging in our people living with HIV. So we are seeing quite a number of people who are aged 40 to 49 who have NCDs. So among the children, we can't say that we reached everybody. So we really can't comment so much about the pediatric, the young people who are living with HIV. But we're able to reach more of the people who are older, 40s, and find that you're having NCDs among the age group 40 to 65. So among our people who are living with HIV who are 60 years and above, we don't expect so many of those people, probably less than 1,000. So we can see actually accelerated or premature aging because of this 32% who are age 40 to 49 with NCDs. And because we want NCDs, which NCDs are they? And And I want to say that the reason why you probably haven't found all these other things that we'll be talking about, like neurodegenerative disorders, heart disease, things like myocardial infarction, or things like pre-MI lesions, because we actually haven't done ECGs and echoes. And this is really just making us think that, we should do a lot of screening for this. So it's really informing our programming, and also what kind of review that we need to give our population that is living with HIV. So what does this mean? What does this mean for us? And I think what we just wanted to communicate today in our CME is that, so that we don't go beyond, so that we don't go deep into the pathogenetic and the biomarkers of, accelerated aging in people living with HIV. It means that we need to start thinking about how we program for senior citizens, and that means that there are opportunities for integration of NCD care and also geriatric care in our population of people who are living with HIV. So I will show us how we've set up our geriatric clinic and what kind of assessment that we are doing. And I'm sorry for these very blurry slides, but this is just to guide us in terms of what should you have for assessment of senior citizens who are people living with HIV. So one of the things we do is, and the components of, geriatric care assessment is just to find out what is the mental status, what is the level of cognition, what is the mood of these senior citizens. And then we look at the socioeconomic status. What's their living environment? Are they safe? Are they able to carry out activities of daily living? What's the social support? What is the caregiver feeling about it? What are their financial circumstances? What is their relationship with family and relatives? And what is their marital status? And then we also need to look at their physical status. What is their presenting complaint? What is their past medical history? What medications are they on? And you can see the thing about accelerated aging is you'll have, multiple morbidities. So one thing that I haven't put in this presentation is that they're actually people who had more than one comorbidities. And when you have more than one comorbidities and you already have HIV that you're seeking care for, you're likely to get polypharmacy. And when you talk about what is the effect of aging on HIV, you're seeing that they actually lower chances of adherence to medication, and there are lots of drug interactions that may occur with the medicine that we are giving. And that's why we're asking ourselves, isn't it better to integrate the care within a HIV clinic as opposed to sending them out to many MOPCs, because of understanding how those different drug interactions are, and also the effect of aging on HIV with reduced cognition. There is also likely to be reduced adherence to medication. And so that's why all this information on the past medical history, on medical reconciliation is important, on the nutritional status. And you find like some senior citizens who go to, some that come to our clinics will actually experience weight loss, and you're also thinking, could this be cancer? But it's actually even an issue of older children going home. We actually have a patient who is on care that could not do an abdominal CT scan because she had to take care of one of her grandchildren who has a seizure disorder. So she was actually prioritizing the care of her family over her own care. And that means even the food security in that house will be lower because she's taking care of other people and not taking care of herself. And let's not forget that even among these people who are living with HIV geriatrics, there are those who will have alcohol and other substance abuse disorders. And we also talked about the effects of aging on the immune system. So you find that they are more prone to infections. You need to encourage some immunization, and you need to find out what their immune status is. And you also need to make sure that we're able to treat them and rehabilitate them, and also ensure that they are able to be taken care of by people who understand their limitations in mobility, their limitations in carrying out activities of daily living. And then the other aspect, which we don't do a lot among the younger population, is what is their functional status? How are there any limitations in activities of daily living? Can they move around? So issues of mobility, how are those issues of how are they able to move around, and also examining frailty. So I'll just I'll stop that share and then just project some of the tools that we use in assessment of the geriatric population within our clinic. I'm sharing it, just give me a minute. Can you see the share? Okay, so I can see the share. So this is the kind of assessment that we do within our clinic. And so to examine frailty, we just ask them this frail questionnaire screening tool. Are you fatigued? Can you walk up a flight of stairs? Are you able to? Do you have more than 5 illnesses? Have you lost weight? And really, with these people. And then also, how much difficulty do you have lifting and carrying room? And then as simply what you usually eat, does food taste good? So what we also do within our clinic is we actually have a geriatric support group. And we actually even have people as old as 90 years within our clinic. So really, this is just to help people to exchange ideas and really to support them during this life stage. You find that some people are now senior citizens, have retired, and I think the outlook of life changes at a certain age. So the support group is really just to address some of those issues. The next steps are thinking about how to plan some interventions around, around the support group and around cognition. And also some of the things we want to do is just do a better screen for degenerative disorders and depression and anxiety among our senior citizens who are living in HIV. So I think that's the overview that I wanted to give, and probably we'll give a more detailed presentation in the coming week. So thank you, Dr. Over to you.
So thank you very much, Dr. for that presentation. It's been an eye-opener, especially with HIV and aging. And I know some of us will have will be asking ourselves, why are we choosing 50 and above and not more than 64? Just an example, in our clinic, for the patients who are more than 64 years of age, we have 300 and around 30 patients. And for those who are between 50 and 64, 2,833. So in 15 years, these patients are going to move into the age group of more than 64. And from the NCDs that we've realized, we've noted most of our patients with NCDs are presenting from the age of 40. And another thing that Dr. you've elucidated is with HIV and aging is the acceleration, or is it acceleration or accentuation of aging within this population and immunosenescence. So I'll just move to the questions and see if we have anything. So there's a question here on whether we have a package of care for geriatrics with HIV. And actually, I think you can take that.
Yes, we do. So I think our package of care includes, first and foremost, NCD screening. So one thing we mentioned is that the first level towards that NCD screening was just asking the patient whether they are on any other medication. So the second level is at the patient's cost. We actually do an NCD screen. So we will do a TBC, we will do a fasting blood sugar, fasting lipid profile. At every visit, we're able to get blood pressure done. We're able to get a BMI, and then we also have a urinalysis. And this is just to look out for the chronic kidney disease, chronic liver disease, cardiovascular disease, hypertension. So once the patient goes through that NCD screen, and remember, because it's at the cost of the patient, we are limited in terms of we're limited by what they are able to afford. So once we do that, we also have the NCDs, the geriatric screening form that I've actually showed us. And then we have clinic on Wednesday and Friday for senior citizens. We can also do it on Monday for those who have NCDs. On Friday, in case we find that they have an NCD that is not well controlled, we actually have a physician who comes to review. So we also have mental health screening for depression, for anxiety, and we have a psychologist, and we also look for, some neurodegenerative diseases like Alzheimer's. We have some patients actually with Alzheimer's, and we refer outside for care. But what we'd want to do is just make it more holistic and have the care given here. Yeah, so actually what we're doing is just documenting the NCDs that we see among this population, following them up, and what we want to do to take it a step further beyond the support group that we have for them and beyond the open days that we have. And we actually have a group specifically for the senior citizens. We want to take it a step further and see whether there are any effects on adherence to medication. What do they feel their quality of life is like now that they've grown older and living with HIV. And we also want to see how that impacts on, prevention with positives, people who are living with HIV. What is the appropriate messaging to give senior citizens? I mean, yeah, so I think moving forward, we just want to see how we can take it a step further beyond what we've been doing.
Thank you for that elaborate answer. There is also one on whether we charge patients at the CCC for the services that we offer.
So we don't charge anything for like reviews within the clinic, but for screening for NCDs that we charge for. That we charged. And one of the studies, we've had actually studies being done within our clinic, because I can see someone asked a question about, do we need to change from TDF to ABC in older patients because of TDF associated osteoporosis? And I mean, that's just the highlight of the talk that I was giving, because we don't really understand, what are the rates of, failing kidney function in these older citizens living with HIV. But there actually a study that was done here on giving, and I think it's still ongoing, in giving, instead of TDF, you give TAF, tenofovir alafenamide. Yeah. So what they found is at baseline, when they're actually just looking at the renal function. Remember, we are funded for HIV care, but we're not funded for NCD screening and creatinine. So what they found when they actually just did at baseline, they found that 50% of these people who are older than 60 years actually had GFRs of less than 50. And really what that means is, within our package of care for people who are living with HIV, we need to somehow sensitize on the need for screening, especially renal. And it's not just for, because I'd like to say for older patients above 65 years, we really need to find out what this cutoff is. For someone who started ART when they were 30 years, maybe that's different than from somebody who was switched to TDF when they were 15 years. So really a better understanding of what really is the cutoff age. We don't really understand that.
I think, Dr. You said it very well. In fact, I can give an example. We have a 28-year-old within our clinic, a 28-year-old gentleman who had been on TDF for more than 10 years and now was presenting with severe osteoporosis and actually on a wheelchair currently. So the question on children, the aging in children, I think it is a very valid question that we need to look into.
I think someone talks about aging is an anxiety, and I agree. And I think that's why we are really doing all these support groups, so that we can reduce this anxiety, or really just help to get people to support each other. And especially what someone asks, how can we address the uncertainty in this age group, which makes planning for care and support more difficult in daily lives. And I think that's one thing we want to grow our geriatric clinic to address. We anticipate, the limitations in activities of daily living, and we're actually able to help you get the support much earlier, but even to just show how you're doing and how you're progressing. So I think, I hope that answers your question. So we're doing it through the psychologists and through the support groups that we have, but we want to further understand how many people actually have anxiety disorder, how many people have depression as a result, so that even our interventions are more informed. So I think this was just a part one of the effects of HIV on aging. That is sort of like an introduction, and I think we'll dig deeper in next week's webinar.
Yeah, actually, there are many questions on this. It sparked so much curiosity. And there is one that I would like us to tackle on any correlation between the different drug regimens that we have for our patients and specific NCDs.
Yeah.
Like what you mentioned on TDF and renal failure.
Yeah.
So can you just elucidate on that?
So great. I think in terms of like quantifying a lot of these clinical manifestations of aging and correlating them to the drugs is probably one of the next steps. Yeah, so we have isolated patients that we can see, but in terms of like really digging deep for this NCD screen, it's really made us think that we need to do a proper NCD census for all our patients who are living with HIV. And when we say a proper NCD census, we just want to find out what are the NCDs and all these things that we're talking about, and really just go dig deep into the regimens that they have ever been on. So I think more information will be available in time. So in terms of the known side effects, we know them, but how many actually among our patients, we can't really tell, because we want to dig deep and just look at all these NCDs and adverse effects of the ART and just see how it correlates with the aging and regimen. But we'll have more information later.
So I don't think we have any more.
Hello. This is Anzala. May I? Can you hear me?
Yes, we can hear you, Dr.
Yes. Yeah, this is a very interesting and very good discussion, because at KAVI in the next coming weeks, we are planning to do some work with people living with HIV AIDS. So my question among these, the geriatrics, and your definition is 50 years and above, or is it 45 years and above?
We use 50 years and above in our clinic, yeah.
50 years and above. And
Yes.
You said you have a population of what, of 2,500 or?
Actually, we have a population of slightly above 3,200 patients who are aged 50 and above.
Okay, now, if you look generally, maybe in terms of just percentage, what percentage of them would you say are very well controlled in terms of viral load? Would you say 50%, 60%?
Just looking at the data, Dr. Ray, we're glad to say that 83% of these patients, though it's not where we would like to be, but 83% of our patients are well controlled. This is with the cutoff viral load of less than 200. Yeah. So we are having 83% of our patients, yes.
Okay, I ask that because there's an interest in looking at the population of that nature, but beginning to think of work in relationship to a therapeutic vaccine. You know, here at KNH, we've been looking for a prophylactic vaccine. The HIV vaccine has still remained elusive, but otherwise we are making some inroads. But I'll be coming to you guys maybe in the next coming weeks to just discuss, would this be a population that would actually volunteer for a therapeutic vaccine of that nature? But that will require that they are in a healthy state and maybe assess immune profiles, but more so those who are very, very well controlled in terms of viral load. We just want to see whether this vaccine we are thinking of can actually be able to boost the immunity further. So I don't know whether that will be of interest to you and Dr. Kamau.
I think we are very interested. I mean, having worked with people living with HIV and really seeing, I mean, that would be something very exciting. And I mean, it would help us to even think around interventions for senior citizens for HIV prevention that I think has not really been studied well. And it's a population that people don't think about. So I think, I mean, that would be an age that we would be interested, and I think would like to have further discussions around this.
Okay. This was actually good because it's a two-pronged approach, and the problem, one of the things that we really want to be able to understand is the interaction between HIV and CMV. Because CMV is one of those things that actually has been implicated in immunosenescence, but also not very well studied. In Africa, nearly all of us get CMV infections very early in life, but how it impacts on our immunity is still not very well looked at. You'll be surprised that they say that our immunity begins to actually decline at the age of 17 because of maybe CMV. Whether that is true, we really don't know, but maybe it's something that we need to look at. And then the other thing, Okach and Kamau, to ask is that, what kind of vaccines do you recommend in these groups? Because there are some vaccines we should really be able to recommend.
So I mean, beyond what we recommend, like beyond the COVID vaccine that we recommended, there's also hepatitis B. There's actually the pneumococcal vaccine that we recommend, and also meningococcal.
And are they getting those
vaccines that we recommend? But I mean, these are just recommendations. We're not able to really do much beyond to give them the vaccines. And we've really not studied what the vaccine uptake would be. And
yes, because that, because
the people that we recommend it to.
Yes, because you see, that is another approach to healthy living. Because part of what we are looking at is that vaccines and vaccine provision is a continuum, and we are somewhat kind of stuck thinking that vaccines are only for pediatrics. So we must maybe think together and even bring in NHIF for those who have covered to say there's a public interest in ensuring that we have vaccines for the adolescent, vaccine for adults, vaccines for the elderly and vaccines for special groups. And surely through NHIF, these vaccines should actually be provided for, so that at least those senior citizens can actually be able to avoid those kind of problems. And pneumococcal is critical. Influenza, for example, is another vaccine that is also very, very critical. So as we plan what we are going to plan with you guys, let us also think of those aspects. What additional vaccines can we offer in these special groups? Because they'll be critical, because your age is, as Okachi said, the age begins at 50, isn't it?
Yes, at 50, yeah.
Yeah, exactly. So let's begin to think of that. But this is very, very good discussion, because this is ideally the kind of things we should be talking about and be able now to assess and say, how can we induce good practice so that these individuals feel and live fully as we go ahead. So I look out for you guys in the coming weeks, and then we can see what we can do. But thank you for the good talk. Over.
Thank you so much, Prof. I think we really value collaboration and exchange of ideas. And I think as a clinic, we're really willing to set the bar high in terms of the evidence that we generate for a lot of our interventions. And we really want to set the pace in terms of what the epidemic is changing to look like. Remember, I started off by saying that we expected by 2030 we'll not be talking about some things. But what are we going to be talking about? And I really think that we really need to examine aging and NCDs. And I think that's the future and that's what I hope that we would all think about. And I think the issues of having NHIF cover for some of these vaccines and really thinking about what our package of care would be like for a person living with HIV, to take over the burden that has been taken by PEPFAR for such a long time in the US government. We really need to get our government to start thinking about what they should pay for a person living with HIV, and how taking up NHIF will solve a lot of these problems in terms of NCD screening.
Yeah, because
So,
just take,
over to you, Dr.
Think of this, what would it take to treat an pneumococcal pneumonia as opposed to giving a vaccine?
Sorry, Dr. Would you kindly repeat that?
Okay, just a minute. You can hear me now?
Yes, we can hear you loud and clear.
Yes, what I'm saying is that, you look at costs involved. What would it take to actually treat a pneumonia as opposed to prevent a pneumonia using a pneumococcal vaccine, for example? Maybe the vaccine is only 2,000, but to treat this individual when they get sick would be in the region of maybe 30, 40,000.
Yeah. I think we're really going to look at what the economic cost implications are. And I think one of the things we really want to do with this NCD census that we're going to have within our CCC, and I think we can also transfer it to different things like, pneumonia. So what's the cost of taking care of a person living with HIV with an NCD? And what's the cost of screening and preventing some of these effects? And the same thing goes for pneumonias. What's the cost of having a patient admitted with pneumonia vis-a-vis actually taking the vaccine or paying for the vaccine? And I think we need more studies in that direction about cost implications so that we can actually inform NHIF. I think we really need to inform a lot of those decisions that are made at that level in terms of cost implications of these interventions vis-a-vis suffering the disease.
Thank you very much for that, Dr. There is one question not entirely related to aging in HIV. There's a question on HPV vaccine and how efficient it is, and how we can curb the myths and misconceptions about it with family planning.
In terms of, wow, okay, in terms of like prevention of cervical cancer, there's one thing that is, in terms of like, there's one cancer that is really preventable. And if there's one cancer that's really preventable, it's cancer of the cervix. And effectiveness goes up to like 95 to 99%. And really, when you talk about myths and misconceptions about vaccines, and you talk about vaccine hesitancy, I mean, there's a lot you need to do. And some myths and misconceptions is nothing really that you can do. But it's really about the education and the messaging that we're giving and involving key people to actually just give the science and the evidence. But sometimes myths and misconceptions actually received more than the science.
Thank you for that response, Dr. Another one, there's a question on high creatinine due to HIV medication and its correlation with kidney failure. And is it only with the HIV medication or even the influence of HIV itself on the kidney? So
yeah, so I mean, it's both the HIV and actually one of the age-related chronic non-AIDS conditions. One of them is actually kidney failure. And that's why you get things like HIV and associated HIV-associated nephropathy. And so when you take drugs like TDF that are nephrotoxic, when you take some antibiotics, when you go to the ward and you're given things like amikacin, you know, so it actually exacerbates when you already have risk. So when I talked about aging, I think somebody had a question, is it the HIV, is it the ARVs? So all this, and that's why we're talking about accelerating and accentuating. It's life, like increased weight gain and raised BMI and ARVs that you have to take and are making this process worse. So there's an interplay of factors. So you can't really point it towards one. And neuroscience, which is a science of, aging, actually says there are multiple factors that are at play in aging, and it's not just one. And the neuroscience of HIV and aging is just the same. There are multiple factors that contribute towards aging. So you can't pinpoint at one. But uniquely within geroscience, you can actually have interventions that will stop aging, even though there are those multiple factors. So I think there's more research that is needed in understanding this, and also in understanding interventions that can actually reduce the rate of aging, so that we see less people who are 40s having these NCDs.
Thank you very much, Dr. for that response. And I see we are short of time. Kindly, let's all give emoji claps for Dr. And I think this is a question, aging with HIV is a very important topic that we need to consider. And I'm glad there is good work going on within our facility, within the clinic, within the CCC on this special population. And like we said, we have around 3,200 patients right now who are more than 50 years of age, and it is increasing by the day. We have the question on aging in children. That is something that needs to be looked into, and CD care in the HIV population. And with aging, is it really HIV itself or the ART influence? So with those few remarks and the excellent presentation, we'd like to close off this meeting. And the slides will be made available for those who wish to know more. Thank you, and over.
Dr. Okat, just to comment on the slides, we don't normally share slides, but we record the session as we have today, and then we'll upload the recording on our YouTube channel. So if anyone wants to revisit this session, you can visit our YouTube channel. It is at KNH Research on YouTube. You can find this and other sessions that we have recorded. Thank you.
All right, sorry for that, Aaron.